Hi, I'm Meredith Marr at the University of Maryland Medical Center Midtown Campus. Today we're discussing breast cancer screening and prevention with Dr. Miles G. Harrison Jr., Division Head of General Surgery and Co-Director of Breast Services at UMMC Midtown Campus. Thanks for being here today.
My pleasure, Meredith.
And thanks to all of you for watching. We invite you to leave your questions for Dr. Harrison in the comments section below for him to answer during this live broadcast. Dr. Harrison, let's start off talking about how breast cancer is formed.
Certainly. Well, as with all cells of the body, there's a normal cell, and in the case of breast cancer, a normal cell then through a mutation evolves to having disturbed nuclear material, and then it goes on a pathway to become an actual cancer cell. The body then perceives that as being different from the other cells, and the problem is that those cells multiply more rapidly than the normal body cell. So that's how the actual mass is formed. So it's a mutation that happens. It's generally in the maturing female population that we see that occur.
Is it possible to have the breast cancer mutation, but it stayed dormant your whole life?
Well, it's not really dormant. As I said, it tends to manifest later on. And I guess dormancy may be a word you can use, but it generally manifests in women above the age of 50 is when we start really being concerned. And we'll talk about some screening issues and when they're supposed to start. But most cancers of breast cancer are spurious in the population. 80 to 85% are. And this kind of mutation occurs, where there are some that are genetically linked, and we will probably talk about those as we move along.
You mentioned the older population. What are some other risk factors for developing breast cancer?
Certainly. Well, there are some relative factors. If you started your menstrual, it is a disease mostly of females. There are 1,000 cases of breast cancer in females to every 1 case in males. So if indeed you started your menstrual cycle early, so that's a long menstrual life is associated with that, because certainly the induction of cancer has to do with estrogens within the body. If you menstruated longer than usual, and generally menopause symptoms start late 40s, early 50s, and so if you're one of those women that happen to have menstruated into your 60s, that's a risk factor. Daily alcohol intake is a risk factor. Obesity, and these are relatively low risk factors compared to a first order relative like mom or sister having breast cancer, or ovarian cancer, by the way. Those are all risk factors.
Are there any types of breast cancer that it doesn't depend on what age you are? It can just be any random assortment of factors that we don't typically think about?
Yeah. There are not types that are specific to age, but it is an equal opportunity disease, unfortunately, and those who don't think young people get that, the youngest person in my practice was 23 years old. This is a person who did not have a genetically linked breast cancer, and we'll get into talking about that a little later, but she did indeed have 2 first-order relatives, older sister, and her mom who had breast cancer. Genetic testing was done, and they did not have the gene BRCA1 or BRCA2, which is the genetically linked breast cancer gene. So that was the youngest, so don't believe that young women can't get it, but statistically it's very low. About 7 to 10% of breast cancers are diagnosed in women below the age of 40.
So outside of doing a self-breast exam, which I understand is still recommended by most breast health.
We all do. A good 25 to 30% of my population actually pick up their own masses and or picked up by husbands, significant others. So I think it is a very reasonable thing to do. It certainly can't hurt. To do self-breast exams. But there are some physicians and some organizations that feel it's not effective enough to do, and it frightens females, and I contend that I can discuss why you exchange fear for information.
So if you do find a lump, is there anything else that usually accompanies it? Is there any pain involved or discharge, anything that would set off the red flag?
Certainly there may be. If it's located very near the nipple, you can have things like that. But most often lumps in the periphery of the breast present as silent masses. That's why we have to have screening to do that. Unlike many other diseases which present with symptoms like pain that allow us to focus in on that area, it's rather silent in most cases. The bottom line is that imaging is our first line of discovery of size and true location, and characteristics. There are many masses that arise that women and physicians feel that turn out not to be cancer. There are many solid masses that are not cancer, the most common of which is something called a fibroadenoma.
Is it any different for men? So men who have breast cancer, do they develop different symptoms than a woman might?
The symptoms are the same, but unfortunately we pick those up at a much later stage. I think it has to do with male psyche, to be perfectly honest. And I'm one of those people that avoids problems with my body until they're at a point where you've got to address them. So it's often picked up at a later stage. There is less tissue on the anterior chest wall, so about half of the males that I've treated over the past 35 years either had growth into the skin above or the chest wall muscle below because of how late they presented to the system to be diagnosed and treated.
What are some other causes of breast lumps, both in women and men, that could be confused with breast cancer?
The most common of which I've mentioned already is something called a fibroadenoma. It too has a relationship to estrogens within the body, and we see that in young females as females start to menstruate and the ovaries are trying to figure out how to do their job. Sometimes estrogen levels in younger females form these masses called fibroadenomas. It's from breast tissue, but it becomes a separate mass, and we even have them grow to sizes as large as lemons and oranges, and we call those giant fibroadenomas. When we have those, it's important to differentiate them from another kind of tumor, which is called a phylloides tumor, and again, probably more detail than we need here. But that's clearly the most common mass. The most common palpable finding in a breast is something called fibrocystic changes. We used to, in our literature, call that fibrocystic disease. I am convinced that it may have been a disease back then because men were making the nomenclature for that, but it's not a disease. It's a natural, normal development where there are multiple lumps and bumps. They can either be solid or filled with fluid, and that's where the cystic part comes in. But they are not cancer, they do not turn into cancer, and they don't have any increased incidence of cancer in the person who has fibrocystic disease.
Would your suggestion then be whether or not, whatever type of lump you find, you should always go to your physician and get checked out?
Absolutely. Younger people, pediatrician and/or gynecologist, older people, and we're all supposed to have primary cares now, should at least point it out to the primary care. And if you're not in a screening age group yet, then there are tests that we can do that don't deliver doses of radiation, even though the doses of radiation with mammography are very minimal now. They're low dose doses with mammography. Ultrasound is probably the way to start with doing imaging for younger people.
Speaking of mammograms, what can a patient expect when they go in for their first mammogram? And if something is found, what are the steps that are usually taken after that?
Certainly. Well, again, when we talk about what can women expect, I do get a description from many of my patients about the pain involved, which has gotten a little better over the years as we've perfected, this technology has perfected the actual machinery of doing mammograms. But one can expect the breast to have to be compressed, and the breast must be compressed, and that's what tends to cause the pain, in order to eliminate false positives. That is, breast tissue alone, if just digitally imaged, can look like a lump unless it is spread out so that it does not project as a lump, and those would be called false positives. I give a kind of crazy example, but my patients understand it. You've just gotten out of bed and there's a lump in the bed. Well, there are many options. That could be a pillow. It could be your husband's leg. It could be the dog. But it could just simply be a lump in the covers where there's nothing under there. And how do we make sure that nothing's under there? We pull the covers tightly, and that would be an analogy to the compression that's used during mammography. Did that make sense to you?
Yes, of course.
Okay,
so if a lump is found and further testing is needed, what does that involve?
Sure. Well, we spoke of screening mammography, and screening mammography is a criterion for screening a population that's at risk that does not have the disease, but you're trying to discover it early. Once you do discover a mass, there's then a mammogram called a diagnostic mammogram, and that involves more views than the standard straight-ahead view, which we call AP, and a view from the side, which we call lateral. It involves an oblique where you turn the patient. It can also involve using an ultrasound as an adjunctive study to gain as much information about this new mass or calcifications. That's something we probably need to mention too. As much information as you can gain when you couple those together. So diagnostic mammography with multiple views and ultrasound are often what we go to help the diagnosis.
You mentioned you've been in this field as an expert in breast health for the past 35 years or more. What are some of the greatest myths that you hear? What do patients come in and ask you about, and you're just like, no, that's not true? What are some of the greatest myths?
I got to tell you that the greatest is that a lump, or which is benign, which means non-malignant, non-cancer, or a malignant mass, arose because of a previous trauma to the breast, and people often reference getting hit with a baseball bat at a picnic when they were younger, automobile accident where they hit the steering wheel, so that's probably the most common one that I hear. People's misconception about very remote relatives. I've got a third cousin, fifth removed. I can never figure that stuff out about relatives. That really does not increase any individual's risk for breast cancer when you have someone that far genetically removed from your DNA.
What about birth control or using deodorants? Those are just two that I can think of.
Very, very, very common discussions. We have not been able to show that using any form of deodorant increases the incidence of breast cancer. There was a phase about 15 years ago where a lot of deodorants were propellants. There was an actual chemical used to allow it to aerosol spray, and it actually went from a spray into a powder. And that was associated with increased incidence of inflammatory processes in the armpit, which we call axilla. And there was also a vague reference to that may have been one of the causes of Alzheimer's, but I think that was debunked. But no, there's no incidence increase in breast cancer with deodorants. You mentioned something else.
Birth control.
Birth control. There is a very slight increase in the incidence of breast cancer in women who have taken birth control pills. I think the most common misconception about birth control is that women who have hormone replacement therapy, and these are women who are entering menopause and having symptoms like hot flashes, which are vasomotor symptoms, who are given estrogens to mitigate that. And so that's the population where we saw a relative increase in breast cancer about 10, 12 years ago, which really started reducing the gynecologist's use of estrogens for replacement.
And does that matter what type of birth control, whether you're taking the pill or getting a shot or a patch? Or?
It was most often associated with the pill, but I really don't know about the shot. I'm not familiar with that.
What are some things that people can do to reduce their risk of developing breast cancer?
Certainly. The bottom line about alcohol consumption and reducing the oral intake of fats, and so trying, if you can, to reduce the incidence of obesity will certainly help to reduce the incidence of breast cancer. Reducing alcohol intake, exercise, all kinds of things that can show some reduction, but it's hard to measure those kinds of things. So
are there any types of foods or diets that you recommend? So for patients who have been diagnosed with breast cancer, what do you recommend for them? Like I just mentioned, is there any sort of like anti-inflammatory diet or anything they can do at home?
Yeah, I'm just not familiar enough with that. I often will, when people ask me those questions, I'll make a referral to a dietitian so that those kinds of things can be discussed. But low-fat diets for the most part, and diets high in protein.
Anything else they can do at home to make themselves more comfortable?
When the diagnosis is made, or is
Correct.
this prophylactic? Well, it really depends on the stage and what you've had done. When we talk about comfort, people who have lumpectomies, as lay people like to call it, they're really partial mastectomies, are basically back to normal life's activities in about a month, even less than that, although there are other adjunctive treatments that have to go on, like radiation therapy to that breast that you've not removed, but you've just removed the cancer. But they're pretty much back to normal life's activities right away. People with mastectomies, there are many comfort measures, I think, that we allow for continuing to elevate the arm of the side of the mastectomy, often mitigates some of the pain that's been caused by having to operate on the axilla to remove lymph nodes to determine whether it's spread. All the kinds of modern materials now for making breast prostheses, which actually fit inside bras, are just amazing. I can recall people from 35 years ago would talk about how the envelope for the prosthesis would irritate the skin on the mastectomy site. Now the materials used are velvet. I mean, they're just really soft, and I have not heard that kind of complaint for the last 10, 15 years. So again, as technology in all phases of our lives gets better, it has spilled over into breast cancer treatment.
Great. We're going to take a quick break to do some introductions behind the camera. We have Angela Jackson and Hannah Braun from the Marketing and Communications Department. We're going to take some questions from the audience. Hannah?
Sure. Suzanne's asking, is breast pain a common sign of breast cancer?
Suzanne, no, breast cancer is not a common sign. I had mentioned to Meredith in an earlier question that the problem that creates the need for screening is that it's rather silent. So when you are in an age group where one could expect that a breast lump could be cancer, getting mammography, getting imaging that will allow us to help diagnose it is what one needs to do. But you can't wait for pain to be, generally when pain is an issue, it is a locally advanced breast cancer we're talking about, and we want to pick it up earlier than that.
Do you have another question?
Yep, Clara has a two-part question. First, is it common for a lump in the breast to appear overnight? And is there a difference between a hard lump and a movable lump?
It is uncommon for any form of lump to occur overnight, but any lump that does occur in that rapid a fashion overnight, 1 or 2 days, is more than likely a lump filled with fluid, and we call those cysts. Solid mass is just, there's one night or 1 week is not enough time for cells to multiply enough to form a solid lump. Can you give me the second half of that question?
Second half was, is there a difference between a hard lump and a movable lump? So kind of goes off of what you just said.
Yeah, I'm gonna, if I could change the word hard to fixed, because a movable lump can be hard also. So yes, we are more concerned about a lump that is fixed in place. Generally that's something that is growing out of the breast tissue and not a separate lump. Most benign hard lumps are mobile, are movable. So that's why I changed that from hard lump to non-mobile.
Sure. Why would it be movable? Could it be just like an inflamed lymph node?
Because it's not no. We're talking about in the breast now. So we're talking about a mass that's not a part of the breast tissue. Mm-hmm. A breast cancer is growing out of the breast tissue. So you can't move it without moving the breast tissue. Whereas a fibroadenoma, you can sometimes move that from its position 2 or 3 inches left or right. So again, we're talking about fixation versus well circumscribed and mobile.
Right.
And well circumscribed and mobile generally portends a benign mass.
Mm-hmm. Do you have another question, Hannah?
Yeah, we have one more question from Veronica. She says, after 2 mammograms, I was diagnosed with scattered fibroglandular breast tissue. Does this mean I'll develop breast cancer?
No. And Hannah, was Hannah correct?
Yes.
Yeah. That's not really a diagnosis. Scattered fibroglandular breast tissue is what every woman has in their breast. That's a description on breast imaging, on mammography, about breast tissue that looks normal. So that's not really a diagnosis. Quite different from having a statement of fibrocystic breast development. I don't like to use disease, and I always hesitate because I got trained in an era where we're still calling it a disease. It's not a disease. So that's quite different than talking about fibrocystic development versus fibroglandular. That's what makes up the breast.
So what do you, when your patients are diagnosed with breast cancer, what are some things that you tell them? What are your top tips to them, or things that you feel they should know?
Mm-hmm. First, it's not a death sentence. We are, if you're unfortunate enough to have to be diagnosed with this disease, there could never be a better time. We know more about breast cancer now than we've ever known. we also realize that there are different forms of breast cancer. Breast cancer is breast cancer, but there are cancers because of some nuclear material that are more amenable to treatment and offer themselves, if you will, to be treated by a larger variety of drugs, both oral and intravenous. We have now sorted out several breast cancer types that we know are much more aggressive, and to that extent we often defer doing surgery as the first approach to it and give medicines. It's what we call chemotherapy, and when you're giving it before doing surgery for breast cancer, it's called neoadjuvant chemotherapy, or preoperative chemotherapy, if you will. So again, our knowledge about tissue types and behaviors of different forms of breast cancer has allowed us to tailor the treatment for a specific kind of cancer. So we're not quite at treating every individual's cancer, but we are at groups of cancer types we have individual therapies for.
For those of our viewers who are watching and still may have questions or would like to schedule a consultation with you or a member of your team, how can you be reached?
Certainly. If you're trying to reach me directly, you can come through my office, which is 410-225-8080, which is in our radiology department, the mammography division, which lies in that department. We do screening mammography on this campus, and that's mammograms done for a particular segment of the population where risk starts to increase. May I speak about that for a second?
Go. You
Great.
speak about whatever you want to speak
Great.
about. You're the expert here.
So, there's still controversy about when you start screening mammography. And one thing's for sure, the AMA and the American Cancer Society for years have been organizations, and many others, who have had discussions about that. And the consensus still is somewhere between the age of 40 and 50. And I and my generation of physicians that treat breast cancer have chosen 40. And the reason that I do that is a vast majority of my patients are diagnosed before 40. And so for the comfort levels of the population that I serve, I've decided to go with the American Cancer Society's recommendation for starting at 40. There is a caveat about that. If you do have a first-order relative, mother or sister, who had breast cancer, then the screening mammograms for the women in that family should start 5 years before the index problem. And that simply means if mom's cancer was at 50, then that person should start screening at 40, because 40 is criterion. So let's move it down. If mom's cancer was at 40, then that daughter's first screening mammogram should be at 35. So 5 years before the index lesion within that family, index cancer within that family. Very important things to know, and it's quite different from diagnostic mammography, which we don't do here. Diagnostic mammograms are the mammograms, as we described, that are done when there is something perceived, a mass perceived either by palpation or by a screening mammogram, or calcifications. These are calcium deposits within the breast, and most are usually benign and just with women who are maturing. That is a finding you see with maturing women. But some calcifications that look a little different, like little grains of salt, if you will, what we call pleomorphic calcifications, can often be the first sign of breast cancer. So those are the kinds of findings that will be diagnosed best with the next level of mammography, which is diagnostic mammography, and that's not done on the Midtown campus. That's done downtown at the medical center, and the whole plethora of services that go along with treating breast cancer are, most of them are contained on the campus. Radiation therapy, which is an integral part of treating breast cancer with less than a mastectomy, with the lumpectomy, as we said, which is really a partial mastectomy. We certainly have medical oncologists on this campus, but the medical oncology department on our main campus is well-renowned and is all part of the multidisciplinary approach to the treatment of breast cancer nowadays.
Great. So just a reminder, if you would like to schedule a consultation with Dr. Harrison or for more information about our breast services here at Midtown Campus, you can call 410-225-8080. And if you have more questions for Dr. Harrison, please leave them in the comment section below, and we'll get back to you within 48 hours. Before we end, is there anything else you feel people should know about breast cancer?
Well, I do want to just remind folks, and it's now marketed so well, that October is Breast Cancer Awareness Month, and You all are probably aware that the Susan Komen Foundation Walk Run was this past weekend, and many activities. I actually spoke earlier in the weekend. And so if you can just avail yourselves of all the information that is now easily and readily available, and just have discussions about that with your children and relatives, I think that the more you know, the better off we all are about early detection. That's the key. Early detection allows us more options for treatment, and certainly produces better outcomes with treatment.
Great. Thanks to all of you for watching, and again, leave your comments for Dr. Harrison in the section below. Thank you.